Yes, we are live. We can continue.
I can start. Okay. Hello, everyone. Welcome back to another session of Physio TV Classroom. Myself, Dr. Rucha Rayas. I'm an assistant professor here at Sancheti Institute College of Physiotherapy in the Cardiovascular and Respiratory Physiotherapy Department. And today I'll be taking a session on inspiratory muscle training. The contents that we'll be covering today are a brief introduction to the topic. What are the principles on which inspiratory muscle training works? The benefits, overview of respiratory muscle function assessment, because you cannot go ahead with treatment without assessing, and the types of inspiratory muscle training with their principles of working. I have also included a bit of evidence base, which will be useful to our postgraduate students and clinicians as well. So as an introduction, when we speak about respiratory muscles, our focus is on inspiratory as well as expiratory muscles. Today, our session here is going to mainly focus on inspiratory muscle training only. Expiratory becomes a different aspect. Now, IMT or inspiratory muscle training is a vital part of pulmonary rehabilitation programs, very commonly used in several respiratory disease populations. And its basic aim is to manage inspiratory muscle weakness, which is a functional impairment. By inspiratory muscle weakness, we mainly are talking about the diaphragm, because diaphragm is the primary inspiratory muscle which takes up most of the work of breathing. And apart from that, you also have accessory muscles of inspiration. As I mentioned, aim is to increase their strength, and IMT can also be used to improve inspiratory muscle endurance. So when we are talking about respiratory muscle function here, IMT can help to improve strength as well as endurance. We can modify the treatment protocols in order to target only one or to improve both. Now, what are the principles on which IMT works? Now, understand inspiratory muscles are basically skeletal muscles, right? So the one thing special about them is that they are also under involuntary control. So we can voluntarily alter the kind of contraction of inspiratory muscles that is happening. And also they are under involuntary control. Because they are skeletal muscles, they will respond similarly when certain principles of strengthening are applied to them. So the same principles that we apply to peripheral muscles will also be applicable here. Now, the first is individualization or individualized treatment, which basically means is, as we know, physiotherapy is tailor-made, right? So every patient's requirements are different. According to that, your treatment protocol has to be specific to the requirements of each individual candidate. Second is overload. When we speak about overload, it means that the muscles are used to performing work of breathing against certain amount of resistance or certain amount of load. But in order to improve their functioning, I need to give them a little bit of extra load, right? So that is overload principle. Third is specificity, which means that we just spoke about it. Depending on what your aim is it just to improve endurance? Is it to improve strength and endurance? How do you want to go about it? So depending on your patient's requirement, you can choose what kind of a training is to be given. Next is progression. So once I have given a certain kind of a load to the muscles, they will train, undergo conditioning. And after some point of time, they'll be efficient enough to take up that amount of load. But in order for them to improve even more, I need to progress, right? That means I need to push them further. So that is the principle of progression. And last is reversibility. So these kind of training programs have to be continued in the long run, because if they are discontinued, then whatever improvement has been achieved can be lost, and the respiratory muscle status may actually deteriorate. Which means that these changes or this conditioning that occurs is reversible. It can revert back to the way it was if the treatment is not continued. Now, what are the benefits of IMT? Before talking about what benefits are, let's talk about who can benefit from IMT. Usually, when we think about inspiratory muscle training, first thing is inspiratory muscles, respiratory system. This has to do with pulmonary disease population. Understand that IMT has been applied in many different patient populations, not just respiratory disease. So it is applicable in pulmonary conditions, no doubt about it. You have lots of evidence on COPD, bronchiectasis, other pulmonary conditions. But apart from that, it is also useful in cardiac conditions, post-surgical, conservatively managed, congestive heart failure patients. There are specific guidelines for that population. Neuromuscular diseases, speech and swallowing difficulty, and also used in sports persons to improve their athletic performance. So we will be going through details of some of these in the future slides. Now, when we say benefits of inspiratory muscle training, how exactly is it going to help an individual? There is improvement in strength and endurance of inspiratory muscles, no doubt. Because of that, there will be improved muscle efficiency. If my muscle is well efficient, it's not going to allow fatigue to set in early, right? So there'll be delayed onset of muscle fatigue. Because the muscles are now better efficient to do their function, their basic function is to deliver oxygen to the peripheral working muscles or tissues. So there is better or improved delivery of oxygen throughout the body. This in turn gives rise to improvement in signs and symptoms experienced by the patient. There is improved functional capacity, and there is, of course, improvement in quality of life as well. Now, speaking about COPD specifically, there is a meta-analysis from 2011 in European Respiratory Journal. It mentions about several benefits of IMT, such as improvement in exercise capacity, dyspnea, quality of life. We just spoke about all of these. Recently, in 2020, there was a systematic review that was conducted on a similar topic on IMT in COPD specifically. It was shown that isolated inspiratory muscle training, that means apart from in addition to the rest of the pulmonary rehab, if only IMT is given, still there was evidence of not just improvement in inspiratory muscle function, but also in overall functional capacity, pulmonary function, without any significant changes in symptoms and quality of life. So here what is important to understand is, agreed, IMT is used in conjunction with other pulmonary rehabilitation interventions, but on its own, apart from others, also IMT has its own benefits. So individual IMT only given to a patient will give rise to benefits, but for overall improvement, it should be used in combination with other pulmonary rehab interventions. Now let's go through an overview of inspiratory muscle function assessment. Now, why am I focusing on assessment here is because if we want to understand training, you have to have a baseline assessment to understand what is your patient beginning with, right? So before training, we need a baseline assessment to understand what is the patient's present capacity, what kind of a scope for improvement do we have. This will help us to better plan and prescribe the treatment program. Always assess before you treat. Don't just simply go and give a protocol because it is available. Check how well your patient is able to do in the first place, and then build accordingly. Apart from that, assessment is important for documentation purposes, because in the future, when you reassess, you are in a better position to track whether your patient is improving, deteriorating, remaining the same. How is your patient status changing exactly? Now, when we talk about muscle function assessment, here today we are going to focus on two types of tests: respiratory muscle endurance tests and respiratory muscle strength tests. Okay. So first, let's talk about respiratory muscle endurance tests. In case of muscle endurance tests, What do I understand by endurance is the capacity for sustaining high levels of ventilation for a relatively long period of time. So even when we talk in terms of peripheral muscles also, we speak about more number of repetitions or the ability of a muscle to perform work for a longer period of time, right? So there are certain tests available: percentage of maximum voluntary ventilation, maximum sustainable ventilatory capacity, limit of tolerance of breathing endurance test, and something called SMIP, which is sustained maximal inspiratory pressure. Now, these are just a few examples. You also have many other such tests as well. What I am covering here is just a part of them. What is important for you to remember is there are basically two types of respiratory muscle endurance tests. First are time-based. What that means is I will give the muscle a certain amount of load and I will check how much time can the muscle sustain it, right? So these are time-based tests. And apart from that, the second type is you have load-based tests in which I give a certain time duration that, okay, the muscle has to sustain a load for a given duration of time. And then I see how maximum a load can the muscle take, right? So this is the basic principle of endurance tests in case of inspiratory muscles. You can read up further about the individual tests and see what is applicable in your patient. Now, apart from endurance, we will go through respiratory muscle strength assessment. Now, strength here is indirectly measured. How is it indirectly measured? If the inspiratory muscles are generating a certain amount of force, they are forcing the thorax open, right? And intrathoracic pressures are going to fall. So more the negative pressures generated, that translates to more the force application by these muscles, which translates to more the strength of these muscles, right? So therefore, this negative pressure generation is used as an indirect measure of how good is the inspiratory muscle strength. Now, there are two methods to do this. One is transdiaphragmatic pressure assessment, which can either be done, of course, it requires a laboratory setup and sophisticated equipment because you need pressure assessment probes. One should be on the pleural side, one should be on the abdominal side to check pressure difference on two sides of the diaphragm. Okay. And it can either be done asking the patient to take a maximum effort, or the issue with these tests is sometimes level of motivation also depends. So if the patient is not well motivated and doesn't put in enough effort, it may not show up, or it may give you a false reading. So in order to eliminate the whole voluntary effort aspect of it, electrical phrenic nerve stimulation may also be used to generate diaphragm contraction and then measure the pressure difference. But like we just discussed, this is a complex procedure. It requires specific laboratory equipment, which may not be easily accessible or available to everyone. So we come to the second option available, which is more commonly used in clinical setups. It is called the maximal inspiratory pressure, which is assessed at the mouth level, also called as MIP or PI max. Now, we'll be going more into detail of PI max because we will also learn about how to use this particular reading for inspiratory muscle training. So what exactly is this? So PI max is basically the maximal inspiratory pressure that an individual can generate. Okay, you can measure it using two types of devices. It could be a digital device or a pressure manometer. We'll come to details of these. The subject is asked to exhale completely, go to residual volume level, then the device is placed inside the mouth and the patient takes as deep an inspiratory effort as possible, or a maximal inspiratory effort. Okay. Now here what happens is the device is actually a closed device. So it is not going to allow air to enter into the patient's lungs. Okay. So it is like closing your nose, closing your mouth and taking an inspiratory effort. Okay. This is called Mueller's maneuver. So it is exact opposite of Valsalva maneuver. So this is the type of effort that is generated, and that gives rise to drop in pressures inside the thorax. So there are normative values available in males as well as females for young adults. Approximately negative 100 centimeters, 100 to 150 centimeters of water is considered as normal in young adults. When we assess this, the patient obviously has to be given correct specific instructions to how are they supposed to perform this maneuver. 3 tries are given, and the least value or the most negative value that the patient can generate is then considered as the final reading. Okay, so that is how you get a reading of PI max. Now, these are the 2 types of devices that can be used for assessments. The first one is called a micro RPM device, in which, if you see, there is a screen available, and the screen mentions the exact pressure that is generated at the mouth level. Okay, so here you can see the reading is around 147. So minus 147 centimeters of water is the pressure that this patient was able to develop. Now, these devices are available in the market, but may be a bit expensive. Other simpler devices available are a mouthpiece attached to a negative pressure manometer. Okay, basically a pressure gauge which has the capacity to measure negative change in pressure. Okay, so this can also be used for the same purpose. Now, let's come to types of inspiratory muscle training and the principle on which each of them work. Okay, so the first one that I've mentioned is mechanical ventilator based IMT. We will not be covering this in detail. It is a whole new aspect to be ventured into. It's not in the scope of today's lecture. We'll be focusing on the rest of the aspects. First is isocapnic hyperventilation. Then is inspiratory flow-resistive loading. Next is target flow or pressure IMT with visual feedback. And last is inspiratory pressure-resistive loading. Now, first let's go through what is isocapnic hyperventilation. Now, if you simply, it's a big term, but if you break it down, it's easier to understand. Isocapnic, capnia, hypercapnia, hypocapnia is related to carbon dioxide levels. Iso meaning equilibrium or constant, right? So isocapnic means CO2 levels are remaining constant. And hyperventilation means an increased rate and depth of breathing, right? So isocapnic hyperventilation basically means that even if the patient is hyperventilating, we are not allowing carbon dioxide levels to change much, okay? Normally, if an individual starts hyperventilating for a prolonged period of time, there is something called CO2 washout which occurs. It can give rise to dizziness, a syncopal episode. That is something that we don't want. So in this case, the device has to incorporate something called a rebreathing circuit, which means that whatever air is being exhaled and it contains carbon dioxide, some part of it also has to be inhaled back during the next inhalation. Okay, that forms a rebreathing circuit. That means I'm rebreathing the air that I had exhaled. This prevents too drastic a reduction in PaCO2 levels. Isocapnic hyperventilation is also called as normocapnic hyperapnea. Basically means the same thing. And it trains endurance only. So note that this type of training is not used for strength increase. It is only used for improving endurance. Now, it requires a rebreathing circuit. These kind of setups are more lab-based setups. These days, compact devices are available. If you look at the image on the right, this is a device called Spiro Tiger, which was developed in Switzerland. It comes with this rebreathing bag. So the patient exhales air, it goes and collects into the bag, and part of it is inhaled back. So these devices are also available, which allow independent use by patients. Mostly, this type of inspiratory muscle training is used for research purposes. Clinically, its application is comparatively less. McConnell and Romer in 2004 have given a training protocol using in isotonic hyperventilation. If you see, intensity is 60 to 90% of MBV. So we just discussed respiratory muscle endurance tests, in which the first one was percentage of maximal voluntary ventilation. This is what they have used for prescription of intensity. Time of the session should be 15 to 30 minutes, one session. That's a pretty long duration. So it can be physically taxing for the subject to perform this. Sessions should be repeated 2 to 3 times a day for at least 4 to 5 days a week. Now, we come to inspiratory flow-resistive loading. Now, in flow-resistive inspiratory muscle training, it is also called a non-targeted type of inspiratory muscle training. What that means is it is difficult to set a certain target for the patient to achieve. Okay. So exact training intensity cannot be determined, which is a major drawback. So these type of IMT devices are not recommended much. Documentation per se or decision on how to progress can be a little bit challenging or difficult in these cases. And the problem here is the patient can alter their pattern of breathing and kind of cheat while using the device. I'll explain in detail. So what is the principle on which this works is the subject inspires or inhales against a fixed flow resistance, and the resistance is changed by changing the device diameter. Now, what exactly happens here is we are going to use an equation. This is Pujols' law, which is for flow or volume flux, which basically means volume flowing through a certain airway. Okay, or a tubular structure. Let's keep it that way. So what happens is, if we see here, if we just focus on the equation, okay, delta P is change in pressure. So more the pressure I generate, more will be the flow, correct? So that is in the numerator. R is the radius or how wide is the opening of the tube. So larger the radius, easier the flow of air. Right? Smaller the radius, difficult the flow of air. Now in the denominator, we have a constant and then there is L. L is the length. So longer the length of the tube, lesser will be the flow, and shorter the length of the tube, greater will be the flow. So here what happens is effort by inspiratory muscles is going to give rise to pressure change. We just spoke about how negative pressure is generated. This pressure change gives rise to flow, right? So let's take an example. Suppose there is a large radius tube, okay, and flow is occurring through it, all right? Now I am going to make a change in the radius, all right? Now I'm going to reduce the radius and take an airway which is a smaller size or smaller radius. Now, if you focus on the equation, it is easy to understand this. What is happening is we are keeping the flow roughly constant. We just spoke that it is a flow-based resistive device, right? Here, flow basically means Q. So if the radius is reduced, okay, but I want to keep the flow constant, I don't want it to change. So the only way that I can do it is by increasing the pressure change, right? So if I increase the pressure change, that basically means I'm changing or I'm increasing pressure gradient, which means I need more effort to be applied by the inspiratory muscles. So basically what we are trying to say is as the radius of the device decreases or as the device size becomes smaller and smaller, in order to generate same amount of flow, I need to put in more effort to create a pressure gradient. Okay. Now, let's look at examples of a few devices which work on this principle. The problem here is, suppose I do take a device of greater radius, okay, versus a smaller radius, because I can constantly change the flow at which air is being inhaled. Patients may actually vary the flow, and you won't know how much it is because we don't have a number which is telling us ki, acha, okay, flow is say these many milliliters per second or liters per second, right? So because it lacks a visual feedback or a quantitative measure, it is difficult to know whether the patient is actually achieving the required target or not. Therefore, it is called non-targeted device. Now, this is an example of a flow-based a flow-based inspiratory muscle trainer. It is called a P-Flex device. So here on the left-hand side is the mouthpiece, and there is a dial which you can turn. Okay, and turning of the dial changes this aperture size. Okay, and as the patient inhales from here, air will flow into the aperture and towards the patient. So if you look at the picture down below, the same device has been shown a bit in a simplified manner, but from the side. Okay, so mouthpiece is attached here to the left end and the dial is on top. Okay, so when the subject makes an inspiratory effort, air will be sucked in through this hole and it will come into the patient's system. And there is a one-way expiratory valve which opens only during exhalation. Okay. Now, how do we change the resistance in this device? So if you look at the image on the right, this first here, the intensity is set at 3 and you can see how large the aperture is. But when the device has been turned to change the resistance to 5, now the aperture is much, much smaller, right? And we had just discussed that when radius decreases, I have to put in more effort to generate the same amount of flow. So by changing the diameter of the device, I am making it more and more difficult, or I am loading or overloading my inspiratory muscles, right? Now, there are other similarly working devices as well. This one is the Inspiratory Muscle Trainer by ICU Medical. Rather than having a dial which turns, it has 6 different attachments, and each of them, if you notice, has a different sized aperture on it. So depending on how well your patient is performing, you can decide which attachment is supposed to be used onto the machine and then allow them to inhale. Now, if you look at this IMT device, it looks very similar to a T-piece, which we attach to a tracheostomy tube. This is the exact benefit in this case, that this end is 15 millimeters, which is the standard size of an artificial airway. So this device can be used for patients who have an artificial airway also. Now, the device on the right is called the breather, which was developed in Australia. And the benefit in this device is, on one side, there is a dial to change inspiratory flow resistance. And on the exact opposite side, if you see the small blue colored marker, on the opposite side, there is an expiratory flow resistance changing dial. So this device allows you to set a certain flow-based resistance for both inhalation also and exhalation also. Okay. Now, in all of these devices, actually, the issue is, we just discussed, there is no visual feedback, right? I don't know whether what is set is what I am achieving or not, right? I can vary my flow. So it is always better to have devices which give you feedback, either quantitative in numbers or simply a visual feedback, which will tell the patient whether the technique is being performed correctly or adequately or not. So certain modifications can be done. Here, it is the same device which we just saw, the breather. Okay, but the modification done here is certain attachments or accessories have been used. The patient is holding something here. It is a pressure gauge. Okay, So the device has been set to provide a certain flow resistance. But while using the device, this pressure manometer will tell me numerically what kind of pressure I'm generating inside my thoracic cage. So because I'm getting a constant visual feedback, I know whether my technique is being performed correctly or not. Okay. Now we keep talking about visual feedback, visual feedback. That sort of reminds us of some devices that we commonly use in many different conditions, right? That is an incentive spirometer. So the question comes to mind, can an incentive spirometer which provides visual feedback be used for inspiratory muscle training? Now understand, primarily an incentive spirometer is not meant to increase inspiratory muscle strength or endurance. Its main aim is for lung volume expansion, but there is evidence that states that use of incentive spirometers has been done and has been shown to improve inspiratory muscle strength and endurance as well. So I'm just going to quote one randomized control trial here performed in 2015. They had taken 3 groups, one which used pressure inspiratory muscle training, second used an incentive spirometer, whole line, which is the volume based one, and there was a control group. A 30-day protocol was given. This was applied on 40 normal healthy individuals, females, and it was found that significant improvement in PI max was achieved with incentive spirometry as well at 15 days and 30 days, along with the pressure IMT group also. So this tells us that in certain patient populations or even normal individuals as well, incentive spirometry can also have an effect or an improvement on inspiratory muscle function or strength specifically. Again, the drawback is that quantitative assessment of capacity and improvement or prescription of intensity can be a bit difficult. Now we come to the pressure-resistive loading devices. These are target-oriented devices. So previously we saw that flow-based devices were not targeted. We could not set a specific target for the patient. Here, in pressure-based devices, yes, we can. Okay, so they are also called threshold devices. Why threshold? Because the patient has to reach a certain threshold and only then inspiration occurs. Okay, so this ensures that the set intensity is definitely being achieved by the patient. These devices can train strength as well as endurance, and the intensity is based on PI max. We've already discussed what is PI max. Now, in these, what is the principle? Inspiratory flow is not allowed till the set pressure is achieved by the subject. Okay, so basically the device remains closed. There is a valve. Okay, I have to make an inspiratory effort, right? And only when the set pressure is achieved, then the valve will open and it will allow air to flow into my system. Okay, so this load is generated, or it is set using a weighted device or a spring-loaded device. The spring-loaded devices are very commonly used. We'll go through some in detail. So there is something called a threshold IMT, or a threshold inspiratory muscle training device. It was developed by Philips Respironics. And here what happens is, if you can see in the image also, there is a spring inside the device, right? And this is the mouthpiece. So when the patient performs an inspiratory effort, okay, this spring is pulled apart, right? And the valve opens. Okay, so only when enough pressure is generated in order to pull the spring apart, only then will inhalation occur. Okay, and during exhalation, one-way valve opens and exhalation can occur through the device easily, right? So the numbers measure negative pressure being developed. Okay, so again, this is also measured in centimeters of water, just like PI max. And there is a red marker here. The red mark tells you how much of a pressure needs to be generated in order for the device to allow inspiration. Okay. So by turning the knob of the device, we can shift the marker up or down. So it basically winds the spring more tightly wound, more difficult it is to pull the spring apart, right? So that is how the resistance is changed. Now, if you see on the right hand side, in this study, the inspiratory muscle trainer, pressure based, was used for a patient who was tracheostomized. So that is another benefit of this device, that it can be used in this patient population as well. Now, apart from the threshold IMT, one thing I would like to clarify: threshold IMT is different from threshold PEP device. Okay, there is also something called threshold PEP, that is a positive expiratory pressure device. They look very similar. Do not get confused. This one is the threshold IMT. Now, similar to threshold IMT, there are also other devices like power breathe, power lung. These are just a few examples. There are many more similar devices. The purpose of this talk is basically to help you understand the principle on which they work. Okay, most of the devices pretty much work similarly. Each has their own pros and cons. Again, I would like to clarify that this video is not for promotional purposes. I'm just giving you examples on what is available and what is commonly used for patient treatment. There are no recommendations per se. Okay. Now, for inspiratory muscle training, like we said, because flow-based devices have a lot of drawbacks in terms of not being targeted, and isocapnic hyperventilation is difficult to use in all clinical setups. So the best option that we have is to use pressure-based devices. So there are certain guidelines or recommendations for certain populations as to how to go about inspiratory muscle training. ACSM, or American College of Sports Medicine, gives recommendations for pulmonary disease population. Frequency should be 4 to 5 days per week. Intensity should be at least 30% of PI max. And time should be either 15-minute sessions twice a day or 30-minute session once a day. Now, minimum 30% of PI max is recommended for this particular population. In other cases, especially neuromuscular conditions or say neural conditions like Parkinson's, etc., much lower percentage of PI max is used to begin with, and then the patient is gradually progressed. So that is why make sure that you go through existing evidence, find out what is applicable to your patients, and then choose the correct type of protocol. 30% has been found based on previous research. Usually, on an average, we consider 1/3 of PI max to be a beginning load to start with, and then you can determine whether to reduce it or to increase it depending on how your patient performs. Again, there are recommendations by European Heart Journal given in the year 2000 for chronic heart failure patients. Frequency 3 to 5 days per week. Here, intensity should be 25% to 35% of PI max, and time would be 20 to 30 minutes per day. So the recommendations are pretty much similar. Coming to spinal cord injury patients. So this is an article from Spinal Cord Injury Rehabilitation Journal. They gave a specific protocol or recommendation for SCI patients. This is high-level SCI in which inspiratory muscles are also involved. Frequency 2 to 3 sessions a day for most days of the week, 5 to 7. Initial endurance load can be 20 to 40% of PI max, or you can also use RPE in order to judge whether the intensity is adequate or not. So on a 20-point scale, they recommend an RPE of somewhere between 13 to 15. Time should be 15 to 20 minutes per session. You can begin with much lesser duration bouts, like 3 to 5 minutes, and then gradually, progressively increase. Progression over 6 to 8 weeks can be done on the basis of how your patient performs. So weekly, there can be an increase of 2 centimeters of water, provided it is not too exerting for the patient. So if you find out that over a few number of sessions, RPE keeps going beyond 15, that means it is taxing the patient too much. It's too much of an overload. So to bring the load down, reduce the pressure by 2 centimeters of water. If suppose patient is comfortably able to perform, rating of perceived exertion is less than 13, that means the muscles are not being loaded adequately. You can increase by 2 centimeters of water. This is a weekly progression that is recommended. And the max that you can go up to is 80% of PI. I have also added a few extra good to read articles. These are systematic reviews or RCTs or meta-analysis on certain patient populations. There is a Cochrane review on multiple sclerosis, effect of respiratory muscle training on dysphagia. We had spoken about swallowing and speech difficulties, right? A retrospective study. Then there is use of IMT to improve blood pressure in midlife older adults. And there is also a systematic review on use of respiratory training in Parkinson's disease. So these are just a few examples. You can note these down. Go through the articles. There are lots of information that is provided. And hopefully it will be useful for you to understand how each condition responds to inspiratory muscle training differently and what kind of benefits are achieved. So what is the take-home message from this session today is, I try to keep it short. IMT is a huge topic. There are so many aspects that I was not able to cover actually. I would basically give you a take-home message. Suspect respiratory muscle dysfunction in not only pulmonary disease patients. We just saw how the benefits can be seen in so many other conditions. So depending on whatever patient population that you deal with on a regular basis, if you do suspect that maybe respiratory muscle dysfunction exists, do assess it and choose a protocol appropriately. Please assess before going ahead with treatment. Choose your treatment techniques appropriately, load the muscles accordingly. So if you want to go through strength training, you will have a greater load, comparatively lesser number of repetitions. If you want to go for endurance training, it will be a lower load, more the number of repetitions. Go through existing evidence, patient-specific evidence, okay? Because evidence-based practice is the best practice. And hopefully this session was useful for you all to understand the principles behind how inspiratory muscle training devices work. And hopefully this information helps you to make better decisions when it comes to planning your patient treatment. So thank you very much. I was happy to conduct this session for Physio TV. I thank the Physio TV team, and that's about it here. I will see you next time in another session. Bye.